Everything's good.
Yep.
Good. Cool. All righty. So today we're going to be talking about calcified canals, which encompasses a lot more than just the canals. This is Pulp Stones. This is calcifications in the coronal aspect, calcifications in the canals itself. Probably one of the hardest things to do in dentistry is negotiate and deal with calcified teeth. So I know that's why you all asked it. Please interrupt me if you have questions. Johnny, if you end up remembering what your question was, go ahead and interrupt me as well. So without further ado, let's get going. Disclosures are the same as always. And as far as calcified teeth, when we look at calcified teeth, there's kind of three different areas that lead us to having issues with treatment. So the first one is going to be calcifications in the coronal aspect. The second one is going to be calcifications within the canal themselves. And then the third is our very favorite pulp stones and all the other fun things that can kind of calcify inside there. And I like this bite wing because it kind of shows a case where you have all of them. So looking over at the bite wing, you can see the canals are definitely a little bit thin here. You can't really see the mesials. Definitely seeing some shrinkage in this canal or in the actual coronal aspect compared to, say, 19. And then you can see the big pulp stone that's hanging out here. And we'll talk about how all of these form and why that's important. All right, so this is our nemesis. This is hydroxyapatite, and this is the main thing that forms in dentin and enamel. And there are different ways that calcification can be induced, but pretty much all of them are inflammation. So there has to be some inflammatory process that starts in order to induce the cells inside the teeth to start forming that tertiary dentin. So this can be trauma. Trauma is a really, really common one. We've all seen though it's been completely obliterated. One of the most frustrating parts about trauma is that the trauma can occur when they're like 12 or 14, 15, 16, and they don't actually have issues until 30 years later. That is a really, really common thing we see where, I got hit in the face with a baseball, an elbow, some kid's head when I was, playing whatever sport. And here they are as a 40-year-old and now the tooth's super dark. I'll show you a case like that here in just a second. Occlusion, when you think about it, trauma is all of that force all at once. That baseball hits all at once. Occlusion, if you have high occlusion or if you're a clencher and grinder, you can actually induce the same trauma. It's just chronic over a long period of time. So on people who are chronic clenchers, grinders, or if you have issues with occlusion, you will see a higher incidence of calcification in these cases as well. Same thing with caries. We'll go deep into this, but with caries, this is more a response to the inflammatory byproducts of the bacteria traveling through the dentinal tubules and causing the inflammation inside the pulp. Then we have restorations, and we'll get to that in a little bit, but anytime you work on a tooth, literally if you adjust the occlusion on a tooth and touch the enamel, there is a response inside the pulp tissue. That's how sensitive our teeth are to any type of inflammation. A new one that came out in the last few years is actually perio. Periodontitis can cause issues with calcification as well. And that can be either from, the etiology isn't super clear. Right now, it's thought that either it's the periodontal bacteria are causing, their byproducts are traveling through the tubules, just like it would with caries, and causing some sort of calcification, or it's the periodontists themselves. It's the scaling and root planing, the osseous, the different surgeries that they do that causes those calcifications. And then the final one is age, and that's always a question is age a risk factor for calcification? I would argue that with advanced age is more time for trauma, occlusion, caries, restorations, and periodontitis to happen to the patient. So don't necessarily assume that when you see a patient who is elderly that the tooth is necessarily going to be more difficult, but they probably had more experiences in life in general, and the teeth have had more experiences, and so you're more likely to have calcification in those patients. Okay, let's start off with trauma. This is a classic trauma case right here. The, completely calcified number 8, the normal looking number 9. I realize I'm looking way over here and can't see, so I'm going to put it under the camera so you can actually see my face. And you can see all the crowns on top of these teeth. So this is, you can imagine the story that happened here. They broke the teeth when they were 16, they had PFMs done, now they're 40, and all of a sudden number 8 is blown up. So how does this happen? With trauma and calcifications, there actually is some pretty good literature on this, mostly the Andreessen group out of Sweden, so thank you to them. But about 1 in 20 to 1 in 4 will develop some level of completely pulp canal obliteration, or PCO. And that's what you saw in that previous case where that number 8 had nothing left inside them. Now, about the same amount will develop necrosis. So this then begs the question, if you are seeing a patient who's had trauma, do you do the root canal right away? Well, I would argue that if we knew it was going to be 1 in 4 chance, probably, because it's much easier to get the root canal done at that point when they're young and everything's wide open. But if you think of it from the reverse, no treatment has a 93% success rate in these cases. Only 7% of them on the low end actually need treatment. Trauma on its own is probably an all-day symposium lecture. If you guys want to have a kind of like, dip your toe into it, I'm happy to put one together on trauma. I really enjoy dealing with traumatized teeth. I think it's a very interesting and challenging aspect of dentistry, but you don't make money on it. It's very frustrating, and they're always going to surprise you with what happens there. So just kind of throw that out there. Discoloration is very common. If the discoloration happens early on, it's usually going to be from hyperemic issues inside the teeth, and the tooth is going to stain red. I actually posted a video just recently on a young girl who I fixed her teeth with bleaching. That was a red one where it had stained through. As we see pulp canal obliteration, what happens is the teeth usually are going to turn either orange or brown. And that's because when tertiary or reactive dentin forms, it forms much faster than your primary or secondary dentin. And so the crystalline structure isn't as neat, and it absorbs more light. And so that's why we see discoloration in trauma cases. It's not just that the dentin has, formed more and it's showing through. It's that dentin is irregular, and so it absorbs more light, and that's where the discoloration comes from. In these cases, pulp testing is unfortunately not very useful. I still do it. If someone comes in with trauma, the first thing I'm going to do is test 6 through 11, even if just 9 hit. It's really good to have a baseline, because imagine they have trauma to number 8 and 7 through 9 all have no response to cold, okay? But 10 does. And they come back in 2 weeks and 7 through 9 still don't have response to cold, but now 10 doesn't either. That's telling me that 10 is probably in the process of dying. The other problem is that thermal testing, like I said, it's not super useful because the trauma can actually cause it to die kind of a little bit, and then they come back to life. So on these, follow-up is super important. Once again, if you want me to go in more detail about this, please let me know. I'll put together a presentation on trauma. So then the question becomes, all right, you have someone comes in with that complete obliteration, there's nothing left. What do you do? Do you do the root canal, or is there another option here? So obviously you will have to at some point create your own canal all the way through one of these anterior teeth. It's one of the hardest and most frustrating things to do in dentistry. However, there are a couple ways you can get around this. So here's a case where her primary complaint was just the discoloration. Cone beam looked clean. And that's the other thing. On these cases, I highly, highly, highly recommend getting a cone beam on them, because while it looks, I don't know how good the projector is, but you can almost see a line running through there. When you look at the cone beam, there's nothing. So I would have to pretty much drill 21 millimeters down to create a canal to bleach her tooth, which leads me to sometimes you can just bleach the tooth, not do the root canal. So this is the case. This is a check film I took as I was accessing to make sure we were, right in line and everything looked good, and started to bleach the case. And what you do is, this is one of those cases where I don't access with anesthesia in this case, because if they feel it during the access, we know that there's enough nerve tissue that they're going to need a root canal. Now, I don't like doing test cavities like this because I think it's kind of archaic, and we have much better diagnostic tools available to us now. However, this is an option available. I would recommend, if you're going to try to do this, access without the anesthesia to make sure that it's going to be okay. Also, you really only want to do this on the right patient. This patient was super intelligent, kind of knew what was going on, didn't want to have any damage to her tooth, and so she was much happier to have a small hole through the back of it. And here's the difference. So you can see why she was upset about the discoloration, and she's in her 40s. She's that classic case, played softball, got hit in the face. You can almost see how 9 is a little bit retroclined compared to 8. That was probably the softball's fault. And even after 1 week, we've already started to improve the color. Now, I haven't finished the case. I'll post it somewhere once we finally see her back and get everything looking beautiful. But no symptoms, no issues with the tooth, and just kind of follow up. So every now and then you do have to do the root canal in these cases, but I just want to throw that out as an option for you. The other thing you can do is, here's another case where once again, really high dental IQ patient. She's a dental assistant at one of my referring offices from a couple hours away. And she had just had these beautiful veneers put on top of there. Here's the problem. Where's my access going to be? It's going to be right through those beautiful veneers. And when you're accessing cases like this, you do need to have straight line access to be able to find them in the anterior. A cingulum access here isn't going to help you find anything. You've got to go straight down there. And so I talked with her about, hey, you know, your veneers could break. This is definitely going to be a complication here. And she didn't want to do that. So what we did was just do the apicone. Flapped it back, cleaned it out, popped it inside there, and she has had no issues with this tooth since then. I don't have a recall. This is about a year ago. Like I said, she works about 2 hours away, but called her and still feeling good. So kind of a cool option there as well. So I just wanted to throw in, you don't always have to drill a hole all the way down. There are some interesting things you can do, but I would recommend doing these on the right patient. Okay, occlusion. If you guys learn one thing from these lectures, it's this dumb image of a longhorn, which stands for what? Johnny?
Global bull.
Bull. Buccal of upper, lingual of lower. I cannot tell you how many times I adjust these damn things every day. Literally, I will see at least 2 patients a day who come in for a root canal, and all I do is adjust the buccal of the upper and the lingual of the lower. That's not an exaggeration. I can literally show you cases after case after case. You're going to see one here in just a minute. With hyperocclusion, though, there's 2 different types. There's the type that comes from the restorative issue, and this one is very easy to fix. So this is, they just had a new crown done, it's high. They just had a filling done, it's high. They're missing a tooth, and the other tooth is rotated inside there, and now there's an interference. That's easy to fix. You take a big old diamond, flatten it off, you're good to go. The issue is when there's some parafunction, because the question that I always ask is, why are they clenching? Why are they hitting their teeth together so much? Just as a reminder, the only time your teeth should ever touch is when you swallow. Your teeth do not touch when you chew. Your teeth do not touch when you talk. Your teeth should not touch when your lips are closed. You should always have space between your teeth. But there are patients who walk around chronically hitting on there. And the question is why? And usually it's either an airway issue, a sleep issue, which is, those are pretty much the same thing, or it's a stress issue. Because when you activate those, the PDL, it does different things inside our body and makes a difference. The problem is you can't fix this. So what I recommend is, as you go on your journey, when you end up wherever you're going to be, start to look for colleagues outside of dentistry that can help you. I work with an ENT in town when I notice that patients have nasal issues for this sort of thing. I work with a sleep dentist who has multiple myofunctional therapists with her to help retrain the tongue. I work with an oral surgeon who does all of my frenuloplasties and lingual frenectomies and things like that. So you need to be able to identify it, but you don't necessarily have to fix it. So just a little soapbox thing of, when you get out there, the world is a lot bigger than just putting the white lines inside the teeth. Right now, focus on that, become the best at doing that, but realize there's a big, broad world out there too. Okay, let's finally get to the case that we all saw. Were you all able to watch the video, by the way? Awesome. You guys are the best. I mean, I wanted to be like, you know, the cool guy and assign a YouTube video as your homework, but it's probably better than reading Pathways of the Pulp, right? Can we all agree on that?
Yeah. When you reduce your occlusion, do you round off the edges of the teeth?
Yeah, I use that barrel burr. It looks like a big old diamond like this.
Yeah.
And that is perfect for that sort of thing. I can get you the guys the number, but it is one of my most used burrs. I discovered it when I was working at a different office and they had it. And I was like, oh my gosh, this thing is amazing. So generally, if I flatten off it, does everyone understand what happens when you flatten off? You're going to create that right angle there. That's a sharp edge that's going to annoy the crap out of the patient. So what you can do is just take that barrel burr on either side and just flatten it off nicely. Now, now you can still do this, just use like a big fat diamond. But when you can actually buy your own things, that barrel burr works amazingly well. They also last like forever. I think I have to replace them like once a month because they're so beefy. Good question though. Any other questions so far? Awesome. So with caries, what's happening here, if you look at the rest of his teeth, and this patient was about 40, give or take, you look at the pulps down here, maybe a little calcified, same thing down here. The premolars look okay, but in general, he's had a heavier dental load is the nice way to put it. He's had multiple restorations. He has a little bit of perio. It looks like he's lost a tooth. These cusps are pretty high. We might be having some occlusal interferences, especially because this one's so flat. And we have the decay in here. So if you take away 2 things from all these lectures, the second one I want it to be is take a bite wing. They're incredibly useful. It tells you such a good story that you don't get from just the PA. You'll notice that most of the images I'm showing in this lecture are bite wings because I can gauge calcification a lot more accurately with a bite wing than I can with a PA. You can charge for it. There is a code for just a single bite wing. You get like 15, 20 bucks, but hey, that's great. But more importantly, it's the information that it gives you. The number of times I found other things that are causing issues is so often. So I take bite wings on all of my posterior teeth, and I really encourage you all, when you get out, to have your assistants do the same. Right now you're in residency. I get it. You don't need to do that on everybody. But when you get out, it's a really, really nice and useful piece of information. So what I wanted to show here was, I did feel bad because I made fun of histology in our last 2 lectures, I think. So I'm actually going to show more slides from histological slices in this than I think I've ever done in any lecture ever. So be prepared. I promise I'll explain them. But what happens here with caries, which is interesting, is the bacterial byproducts will actually travel farther than the actual bacteria. So if you look at slide A up here, what we're looking at here, this is dentin. And all these little purple things right here are caries. This is bacteria. So if you look at the extent, they got down to about right here, give or take. But you'll notice this is all tertiary dentin. Notice how I said it's arranged differently than the secondary dentin. Look at this is the zoomed in version of it. This right here is your secondary dentin. This is tertiary reactive dentin. Now notice the bacteria are almost, I mean, if that's 0.2 millimeters, they're almost 2 millimeters away. However, this is enough that their byproducts can travel through the dentinal tubules and actually cause the osteoclasts. These are the only alive cells right here, are these guys, sorry, odontoblasts, to start to make tertiary dentin. So that is one of the interesting things of how caries works, is it will actually travel. As soon as bacteria start invading inside a tooth, the pulp knows it and starts to create a calcific barrier. Now, if it is slow like this, it's going to cause slight inflammation and you're going to have calcification. If it's fast, however, we're going to be looking at something like this. Now, look at the size of the pulp here. This is probably a younger person. This actually looks like a primary tooth potentially. But look at how deep the decay is here. You'll notice in this corner, this is the zoomed in version of it. This is all necrosis. This is bacteria. This is necrosis of the pulp right here. And you can see just how many cells are trying to come in there and stop the invasion of the bacteria. So this is why you tend to not see lots of calcification on kids that have deep decay. Partially, it's because there's not as much distance between where the occlusal surface is to where the pulp chamber is, but it's also because the cavities that kids tend to get, if they're not cleaning their teeth ideally, are super aggressive and grow so quickly the nerve doesn't have a chance to respond. I'm sure, do you guys work on kids at the clinic? Yeah. Every now and then. Okay, yeah. I don't know. We've never really liked working on pediatric patients, so we didn't see too many. And you guys have pedo now too, so I didn't know if they were taking over them. Anyway, I see a fair amount of kids, and they are some of the easiest root canals from a technical standpoint because the caries has created an access larger than a first-year dental student's. It is the biggest, largest. It's pretty much just a shell of enamel on there, and it's because once it gets inside there, they go hog wild, and there's other reasons for it as well. But this is what happened in this patient's situation, is that decay was a little bit slower. He had already had a lot of restorations and he had calcification inside there. Okay, restorations. This is the case I told you I was going to tell you about. Looking at that bite wing, what do you think the problem is?
Cusp on number 3.
Sorry?
Occlusion?
Yes. I mean, I did the research. I kind of helped you out here. Guess which cusp was causing the issue? This distal buccal one right here. So the dentist had, to her credit, had flattened out the occlusion. Look, there's really like no anatomy on 30 if you look at the picture of it, but look at the cusp on 3, and no one had adjusted this. This was what was causing all the pain down here. That's why the bite wing is so useful, because now that you see it, it's almost impossible to unsee it. Look at that bite wing and notice how, if you look at the occlusal plane here, look at how much lower that cusp is than the other teeth right there. And that's where the issue comes in. So as far as restorations and the literature, there hasn't been any study done recently on modern restorations. So doing a crown versus an inlay versus an onlay versus like an injection molded composite versus, because we've had a lot of advancements in restorations, and there hasn't been anything on using lithium disilicate versus zirconia versus PFM's golds, the old, the older style crowns. There has, however, been stuff on amalgam and composite. I'm happy to say there's no difference between the two of them. But what is interesting is that the amount of calcification in pulp stones is correlated to how deep the restoration is. So if it's shallow, which is only a third of it, it doesn't actually cause that much calcification. If it's medium, which is 1/3 to 2/3 of the dentin levels, they actually had the highest level of calcification, whereas the deep ones, which is between 2/3 and to the pulp, had the same amount as the shallow. And I think the reason why is what we talked about earlier. If the inflammation is slow and chronic, it's able to create more of a calcific barrier. If it's so deep, the body doesn't have a chance to really respond to those caries or whatever caused the restoration to be that deep. And so it doesn't have time to build that barrier. So something to consider here, if you're seeing the restorations and they're kind of that medium level, anticipate a little more calcification. Okay, so with restorations, what happens when you put something on the pulp? Once again, this could be an entire hour lecture on direct pulps versus indirect pulp caps, but I wanted to give you all just a kind of brief overview. I know you'll get this in classic, but even adjusting the enamel causes a reaction inside the pulp. So what happens if you actually put a restoration inside the pulp? It really depends what the restoration is. In general, the deeper you go, the more of a reaction you get. If it's that medium level, it's probably going to be calcification. If it's deeper, it's probably going to be a little bit of necrosis, which sometimes the pulp tissue can respond to and heal. Sometimes it dies, and that's when we get involved. If you do too close, especially with etch, it's going to cause necrosis. And this is the third thing I want you to take away from our lectures, which is etch is terrible for the pulp. This is the one thing. We all remember how much fun it was doing pulp bio and learning about all the interleukins and all that fun stuff and having to teach each other because we were so good at that. You guys still have to teach each other, right?
Oh, yeah.
Oh, yeah. Yeah. Wasn't that so much? Is it still at 8 a.m.?
Kind of all spread out.
Okay. We had to do it like Monday morning, first thing, and it was terrible. Hatton fell asleep during most of the lectures. And we'd ask him and he'd be like, I don't know, you guys are teaching it. So anyway, with etch, the one thing I did take away from pulp bio is if you etch, and it doesn't matter if it's a total etch system, so phosphoric acid, if it's a self etch, whatever it may be, if there's less than 1 millimeter of dentin between the pulp tissue and where your etch is, you're going to have a really bad response from the pulp tissue. And so the way that I kind of judge that is, can you see pink through it? If you can see pink showing through there, you do not want to touch it with any form of etch. What you want to do instead is use a glass ionomer. Now, glass ionomers have the inherent ability to actually bond to dentin even without a conditioner. So in cases where I'm doing an indirect pulp cap, what I will generally do, now I'll actually place SDF as well, because that helps calm down the pulp tissue and helps kind of arrest any decay. But I will actually leave a little bit of decay if it's not too soft, and place glass ionomer on top of it, and then do the regular bonded composite with etch. That is super key. You do not want to expose the pulp if you cannot get to it, which leads us to the question of, do we want to do direct pulp caps or indirect pulp caps? If you can avoid it, do not expose the pulp. That would be my recommendation. There has been some really good literature about selective caries removal, about leaving some decay. And with the new techniques we have, there's some really cool things you can do. There is a new product out. Have any of you heard of Activa? Yes?
We use that at my old clinic.
Awesome. Cool. What did you think of it?
I like it. The
You like it?
It's real nice too, with like a little needle you can bend so you can put it right where you want it to.
Yeah, it's for those of you who don't know what it is, it's kind of like if BC Putty or MTA was in a composite form and had the same handling properties. It's a bioactive composite pretty much, and it does amazing things for the pulp tissue. I haven't had a chance to really play around with it too much, but I'm really excited to see what we can do with it. I think this could be a game changer for a lot of the pediatric patients. I know the pediatric dentists that I work with in town love this stuff. So it's a really cool material. I just haven't had the chance to kind of play around with it yet. So anyway, once again, if you want to lecture on that, let me know. Yeah. All right, perio. Now, what's interesting with perio, it's kind of like I talked about. It's either from the perio bugs or from the actual periodontitis itself. But what you'll see here, this is the close-up. I told you, this is more slides than I've ever used from pathology. But along here, this is your dentin. And what you're seeing here is the start of the calcification process. I took this from a study that was on perio. So this is actually the pulp tissue, and you can see the calcification occurring here. For bonus points that you guys may have to know for your boards, does anyone know what this little 1 cell thick layer is right here?
The resorption sheath.
Nope. It actually stops resorption. So that should be a clue.
The
Go ahead.
PRR, the PRR,
What you're trying to say.
Close.
The pericanal.
PRS.
The resorption sheath.
It's predentin. So there's a 1 cell thick
Same
layer.
thing.
What'd you say?
It's not the same.
I'm wrong.
Okay.
But it's part of
I love it. So that 1 cell thick layer is actually all that stops osteoclasts from attacking your dentin. So when you have the more traditional internal resorption, it is because of a breakdown of this cell layer, and then the osteoclast can get in and start to eat away at the resorptive. So you don't always see it, but I thought this was kind of cool that this is a very well done slide, and you can actually see the pre-dentin coming along here. So this right here is all that is protecting our teeth right now from internal resorption. And all it takes is for this to be disrupted. They show about 20% disruption is what it takes for resorption, and that can actually start the resorptive process. So kind of interesting, but I thought that was kind of cool. See, I do actually like histology. I just also like making fun of histologists when they are silly about things. So anyway, for perio, what the studies have shown is that you're not going to get as much calcification coronally. You get some fibrosis, but that's not a big deal for us. We're going to clean it out anyway. Get calcification at about 10%. The problem is in the canals themselves. Apically, you're going to start to see more secondary dentin formation with fibrosis in about a quarter of the cases, and calcification in almost 2/3 of them. So if you're working on patients who have perio, be prepared that it might take a little bit longer to get down those canals. Which leads me to the final thing that can cause it, which is age. This is the case that I did yesterday. Anyone want to guess how old this patient was? $60 to $70, $70, $80, $80 to $90, $90 to $100. Who wants to guess?
90 to 100.
90 to 100. Nice job. She is 96 years old. She was lovely. She had Parkinson's. She didn't speak, but she smiled the whole time and responded with yeses and nos with her head. So she was fantastic. But as you can see, that 14 is a little bit of a mess. I was looking at that case. I was a little concerned of, oh God, how long is this going to take? It actually wasn't bad at all. Did I record that one? I may have recorded that one. Anyway, I thought it was going to be a lot worse. It really was a straightforward case. Didn't have to do, the access was still pretty small on this one. Took me probably about 30 minutes. All in all, it was actually not that bad. But the thing I want you to notice is look at 13. If I took out 14 and just showed you 13 and told you that was a 45-year-old, you'd probably be like, okay, guess they had some molars that were lost. But with calcification, the amount of work that's been done on there, which restorations, caries, perio, whatever it may be, is tooth dependent. So you can have cases on elderly patients where they still have wide open canals, but if they've had a lot of work on them, they can be completely calcified. So this is just my way of saying, just a reminder that age isn't necessarily an idea that is going to be a problem. So, okay. Now, I think a lot of you are asking, why the hell did we just spend 30 minutes talking about how this sort of thing happens? And I know why you asked me to put this presentation together. It's because these are some of the hardest, most difficult cases to handle. And I will gladly tell you what files I use, what my protocol is. But if you don't figure out the reason, knowing how these things happen and knowing how you want to approach them is what's really, really important. All of you are professionals. You have all graduated dental school. You've all gone through so many things to do this. And while you may have a little bit of a road ahead to really feel comfortable with doing these, you are already way ahead of the vast majority of people who do root canals, which is fantastic. Also, you're going to a really good program, so that makes a difference too. Now, most of what people want, and if you go to any dental meeting, it's all about the how and what do you use. I have seen people literally throw journals over a 3504 versus a 3004, like literally behaving like children. He's actually was a dean at a dental school in Texas. That's all I'll give you. But like literally behaving like children over what do you do and how do you do it? And that's one of the most common questions I get is, what file system do you use? What do you do here? What do you do here? And the question that I want all of you to start asking is, why are you doing this? And knowing the background makes you that much better. And so the analogy I like to use, I think we all have, actually, sorry, one of the things that one of my very favorite quotes of all time is from Dr. Hatton. First day of residency, he walks in, scares the shit out of us because of course he does. He's terrifying. And he says, you spent the last 4 years learning what to think. I have 2 years to teach you how to think. This is one of the most impactful quotes on my life, because learning how to think and figuring out the answer for myself by looking at the whole picture and not just what do you do has made all the difference in the world. And I hope this resonates with you and you do the same thing. To give you guys a really good example of why this is important before I go and spend the next 30 minutes telling you about what I do. We all have that person in our family, might be a grandma, might be a grandpa. It's my grandma for me, who makes a dish better than anybody else. We all have this, right? Your mom might be the person. Usually it's a female. And from mine, it's my grandma. This is my 96-year-old grandma. She loves hazy IPAs, which is hilarious. 86-year-old grandma. Sorry, she's going to kill me that I said 96. And she makes the best cherry pie in the entire world. And I've got the recipe. She's taught me how to make it. She's taught my wife how to make it. She's taught my mom how to make it. And nobody can make the recipe just like her. And we use the exact same thing. We use the same time. We use the same flour, the same Crisco, because of course it's Crisco to make it. And it's not as good as when she makes it. And that's what I want to kind of get to you guys, is what I'm teaching you is my way of making a cherry pie, my way of doing these calcified teeth. So take what resonates with you and use it, but don't think that just if you do the exact same things I do, you will have success with calcified teeth. This is really, really hard, and take the time to work through each case individually, and you will eventually get it, I promise. Okay, with all that being said, let's talk about what you all came for, which is how the hell do we deal with these cases? Because they are definitely difficult. And while you may feel that you're in a fire when it's going on, I promise you, take a deep breath, it's going to be okay. So, starting off with your access strategy, you're going to have to do more of a straight line access here. A lot of the minimally invasive endo relies on having a pulp chamber you can drop into so that the chamber has done that really small access for you. I don't know of any burr that can create a shape like this. I know lots that can create straight line. I don't know many that can create curves like this. And that's how we get those super, super tiny, like 1 millimeter access size. For a calcified tooth, unless you're using some guided things, which are pretty cool, you're going to have to make a larger hole. In this case, the Caries did it for me. So this obviously is not minimally invasive. I mean, a lot of people would say the canals were, but the access wasn't because the bacteria did it for me. And so that made it a little bit easier. Now, that being said, know your general anatomy. This is where the cone beam comes in so much. I take cone beams on all my patients, and I really encourage you to do this once you get out into the real world. I know it's hard right now with the school, but cone beams are so, so, so useful. Oh, Sarah's back. She actually popped in.
No, she's not back.
Yeah, she's back.
What?
Yeah, she says it's connected to audio. She's back.
Oh,
I just dinged.
I'm back.
She's back. Yes, who's back? Anyway, Sarah, you came for just the best part is the actually how to deal with these cases. So
perfect.
Before you get into the case, I usually like to spend about 5 minutes going through and looking at it from all different angles. I do this for pretty much all of my cases because it's kind of like going in to meet an old friend. When you go back inside there, you know exactly what you're expecting. You know how long it is. I measure every single tooth to know, is it a 16 millimeter tooth or 25? Because that's going to change a lot of how I approach it, and how far it is between the cases. So really, this allows you to plan beforehand. No general surgeon is going to go in to remove your appendix without first reviewing the imaging. Same thing with orthopedics, same thing with any of the medicine. And so we have this great tool available to us. So use it, take it on every patient. And the more cone beams you take, the faster and better you'll get at reading them. And the more you'll have an idea of what is normal and what looks abnormal for when we're kind of chasing zebras and trying to find things like cancer or other weird pathological things. So take your cone beams. I know you're in residency, but hold this with you. Take it when you get out. Okay. As far as measurements, I always measure canal length on every single case. Like I talked about, it makes a big difference. I sometimes will do it for each individual one. Sometimes I'll do just kind of a general idea because I'm going to be using it. But it really does help to know how far you have to go. So if you're on a calcified case and you know, okay, I should be at about 20 millimeters, which is what the cone beam says here. Well, if I'm at 16, I got a lot of work to do. If I'm at 19, oh, this isn't going to be too bad. I maybe don't have to do as much stuff. Okay. Distance between canals is super huge as well. Can all of you, if you were working on a case right now and I told you, oh, it's 3.5 millimeters from MB1 to MB2, can you all visualize what that distance looks like roughly? Yeah. This is where, as you start to measure more and more, you'll start. Oh, shut up, Siri. Sorry, did I say anything that even sounded like that? Sorry, my phone decided to wake up. The more and more you start measuring, the more you'll get an idea of what it looks like when you actually find them. So you'll know, okay, this is what 2 millimeters looks like. This is what 4 millimeters looks like. And I always have the cone beam up in the room because it does take a few minutes to load. So I want to be able to, if I'm troughing for MB2, I can pop it open right away and not have to wait the few minutes for it to load. Okay, so start doing this, especially with your calcified cases. Measure so you start to get an idea in your head how far it is from one to the other. Okay. Pulpal floor depth is useful on cases not like this one. This was caries, so I'm going to remove the caries and expose it. But on a case that's completely calcified, if you measure to where the pulpal floor is, you can. I have taken if you take like a 50. The stopper on a 50 file, so an F5 or a like 50 headstrom, pop that off. You can put that on a long skinny diamond and actually measure. So when you drop down, you don't go beyond where the pulpal floor is. I usually like to go about 1 millimeter short to do an initial access, and then I'll do like a light brushing motion to get a little bit farther. But that's a way to make sure that you don't perforate through in these cases, because that can occur. The other thing that I like to do, especially with anteriors or lower teeth, is find out my straight line angulation. And so what that means is on especially lower premolars, the roots are pretty straight. The problem is that crown can be almost 30 degrees tilted either buccally or lingually. And so sometimes the best way to access it is straight through the buccal cusp. Sometimes the best way to access it is straight through the lingual cusp. And you don't know that unless you do this measurement on the cone beam and figure out what is the best way. Because with calcified teeth, the way you're going to need to put pressure needs to be almost in a perpendicular area. So you do need to have straight line access. And this is another tool you can use to kind of do it. So take cone beams on all these patients 100% of the time. All right. So we've accessed the case. Now what do we need to do? When you're accessing, I always like to sacrifice the restorative material over the tooth structure. So I might make a larger access in the crown because it doesn't matter, I'm going to replace it. I would definitely remove most of the composite if it's a retreat or something like that, because we're going to replace the composite. The one thing you cannot replace is tooth structure. So try to save as much tooth structure as possible, but don't hesitate to remove more material than you would normally, because you can replace that. All right. The way they teach you is to aim for the largest canal, which is usually the palatal on one of these or the distal. I'm weird. I like going for the MB1 first. I don't know why. Once again, this is like a grandma's cherry pie. I like going for MB1. That's usually the one that I am aiming for, but it's usually easiest to find the largest canal, which is either going to be a distal on the lowers or the palatal on the upper, but try to find that one first. In a case like this that's bleeding, it's pretty easy to see where they're coming from. This was a vital case. Oftentimes, there's going to be nothing left inside them and they're going to be necrotic. I like to access dry with a long skinny diamond. I use this light brushing technique. And most importantly, if you have the assistant in the side scope brushing air on there, what happens is all that dust will fly out except for in the one spot where your canal is. And that's how I find a lot of these really, really tiny ones where it's like 6/100ths of a millimeter, that all you can get in is the tip of a 6. The way you find these is by doing it like this. Accessing dry, you're not going to create a lot of heat. You're really only going down maybe a 1/10 to 1/4 of a millimeter at a time. So you're not going to create a lot of friction inside there, but it allows you to find them a lot faster. Okay, I'll explain what that is on the right-hand side here. But once you've found one canal, it becomes so much easier. Their teeth tend to be symmetrical. So lowers tend to be symmetrical, back and forth. Uppers are a little bit different depending on which one it is. But once you've done a few of these, you'll figure out roughly where they're going to be. I like to open with a flaring file. I use a 2006, and that just gives you a larger reference point. So instead of, like that palatal being super tiny and you're trying to find everything, quick open it up. Doesn't take that much time at all to just, go down about, 5 millimeters, if so. But now you have a much larger hole. So when you're trying to find the rest of the canals, you can see exactly where it's going to be. I'll show you in a minute how that works. If you have issues getting down them, work up the 6, 8, 10, like we talked about. What you're seeing on the right-hand side is those are the chapters that I put for the video. It took over 12 minutes for me to get down everything there, and that's with me cutting out a lot of the rinsing. So these can take some time to get down. I know all of you would love to say that it took you 12 minutes to, get patent on a calcified case. I promise you'll get there. Just realize these things do take time and you do have to be patient. Often, this is where I'm going to have that cone beam up in the room so I can see, okay, where do I need to go? How much farther is it? I'll measure between like MB1 and distal buccal, between palatal and DB, just get an idea of where I need to go. But this is where that cone beam is extremely useful. The other thing you want to do is look for color changes. If it is a fast case, it means that they don't have a lot of time to get calcification in the chamber. What you'll often see on the floor is you'll see a darker line. I see this a lot on lower molars where you can almost see the line running from where the mesials are down to the distal. On cases where it's been a slow calcification, what you're going to see instead is a bright white calcification. So we're talking piece of paper white. And that's where you want to slowly start troughing through because that's your reactive dentin. Remember, the reactive dentin, because of how it's formed, it doesn't have the same crystalline structure. So it's going to absorb light differently than your normal secondary dentin. Any questions so far? I know this is a lot. You good? Johnny, did you figure out the questions you had from my video?
That was one of them that I had a little earlier, but no, they're still coming in.
Good. All right. Okay, so we found them, but we need to start to do some troughing. So what I like to do, let's say I haven't found MB2 in this case, what I do is in my mind, I draw a line between where the palatal and the MB1 is, and then I draw a line that's roughly perpendicular between the distal buccal to this line. What you're going to find is in general, the canal is going to be symmetrical over here. Now, all of you are saying, but this canal is over here. That's actually not symmetrical. Remember from the video, this thing moves about 3 millimeters, both mesially and buccally. And that's really common with MB2s. The initial point isn't always where it ends up. So the initial point that you need to look for is usually going to be symmetrical. Where the canal ends up can often be out in no man's land. And I've seen MB2s end up like way over here as well. This is where that idea of troughing using almost the comma between the MB and the palatal, this is what you want to do. If you would just troughed straight along between the MB and palatal, you're not going to find it. You need to go slightly mesially and make that curve along here because that's usually where the MB2 is going to be located. Does this make sense?
Yep.
Cool. Okay. You can use whatever you want. I am a fan of high speed, so I use a skinny diamond for like 99% of these. If it gets deeper, I'll switch to ultrasonics. I'll show you which ultrasonics I like to use at the end here. You can use Munt spurs. You can use whatever you want. Pick your poison, pick your favorite one. Regardless of what you do, you don't want to be pushing apically. You want to gently brush along where that line would be, kind of along the comma that I was showing earlier. And you don't go down very far. We're only going down maybe a tenth, like I said, 1/4 millimeter at a time. Go down, brush really gently, air it off, and try to look for any spots where you see debris accumulating because that's where your canal is going to be. We'll talk about when to stop in a minute, but in general, about 3 millimeters is how far I like to go down for this process. Okay, so let's say it's a case like the one that we were, the video of it's calcified in the canals. What the hell do we do? In general, this is something I hope is helpful to you guys. This is how I teach my assistants, is there are generally 3 phases to endodontics for a root canal. You have your access, you have your cleaning and shaping, and you have your obturation. Does this seem all fair? Okay. The one that is by far the most variable is the access. And I define the access as removing all of the decay, restorative material, locating all the canals, and getting about halfway down to the point that I'm ready for working length. So to me, that's the delineation between starting the case and moving on to cleaning and shaping is when I go to get working length. This can take 2 seconds if you just drop right in and you're good to go. This can also take 2 hours or 2 appointments. So it is by far the most variable process. Everything else after this should be really straightforward. So Cleaning and shaping, I end that when I don't see any debris or drainage or anything like this. I include the rinsing or the gentle wave or whatever we're going to use in that. And then the one thing to consider is there is a fourth one, which is the restoration, but we can talk about that at a later point. So what we are still focusing on here in my mind is the access, because we haven't really gotten working length. The way you negotiate these canals is all up to you. There are all sorts of different materials that companies will sell you. Does everyone know the difference between a K, a C, and a C+ file? Yes? No? Rohan, you're nodding slightly. I might make you answer. Rohan's nodding slightly.
I mean, they're generally stiffer. I think they have the same taper. C+ may have a greater taper.
Nice job.
C+ has greater taper.
Yep.
Yeah.
So Ks are an O2 taper. Cs are an O2 taper, but they're made with a stiffer metal. Both of those are non-cutting at the end. So the end is blunted. The difference with C+ files is they are sharp on the end, so they can create their own canal, and they are stiffer. So I would never recommend dental students ever use C+ files, never recommend general dentists use C+ files. If you're doing those, just send it to an endodontist. But for all of you, this is where these do come in handy. You do have to be careful. I have definitely made my own canals with these, mostly in residency, but that's why we go to residency, is to learn. So these are a very useful tool. I think in the video I used C+ files because of how calcified it was. You can also use chemicals. So EDTA, Glide, other options like that. Be careful because you can over soften things. Rotary versus hand, I tend to go more for rotary just because it's a lot easier on my hands, and more importantly, it pulls debris up. So I don't want to be compacting stuff down, which is what C files do. So using rotary files will actually pull debris up. Make sure you're rinsing a lot with these. You do not want to compact debris down because it's a really, really, really bad time if you have to get that sort of thing out. If you have ledges, the easiest way to get around them is pre-bending 6 files, kind of working down until you feel it slip around there. Once you're around the ledge, recapitulate up and down a bunch of times, and then move up one size. Eventually, do it by hand using a rotary file, same thing. And then once you get around it, poke it up to the handpiece. It'll start spinning and should soften out that ledge, and you can get around it like that. Okay. When do we give up? Or in this case, when to pause. One of the beautiful things about endodontics is we do not have to do every case in a single visit. It is very easy to throw calcium hydroxide in, bring them back in a month. I tend to pause if I cannot see anything and I'm 3 millimeters down. I'm going to pause and take a cone beam and see where it is. If you perforate, repair it, let the patient know. But after you perforated, no one's in the right mindset to go find anything after that. Let the material set up, go take a cone beam. You'll know where to go after that. I have a case where that I'll post eventually where could not find MB2, completely calcified case, perforated, repaired it. She came back a month later, and because I had the cone beam and wasn't an hour into the appointment, very easy to find MB2 and complete the case. Broken files, if you can get them out, and if you get them out obviously right then, but if it's pretty far down, take a break, come back, try again another day. And especially if you feel yourself starting to get frustrated. So much of endodontics is your mindset. And if you are struggling and just cannot get down something, take a break, take a breath, go have a cup of coffee, come back another day and try again. You will get a lot better at this as you start practicing, but it's very common to become frustrated with these cases. The other thing is time. If you are multiple hours into an appointment and the patient's starting to get uncomfortable, you're starting to get uncomfortable, nobody's doing a good job at that point. Pause, come back, and try again. Okay. Once again, it's okay to take 2 visits. So calcium hydroxide is a really, really useful tool. It can soften canals. There's big, heavy air quotes on that. But I'm going to show a case here where it actually made it a lot easier for me to get down there. It also makes it, if the case is a type 2, super obvious. There's been multiple times where I've been struggling with MB2, cannot get down it. I put calcium hydroxide in, and what do you know? It comes up the MB2. The problem was the MB2 came in almost at a right angle, and no file is going to negotiate that. So I knew I was fine to finish the case next time, fill it up, and you're good to go. It also is like a proof of concept. So if you're short, if you can't find something, whatever it may be, if they come back asymptomatic after a month in calcium hydroxide, they're probably going to be okay. We'll talk about that in just a second here. So here's a case that I did through this bridge. I struggled to get down those mesials. Distal was fine. If you look at the pre-op, the distal's pretty wide open, but those mesials just were absolutely awful. Came back a month later, dropped a 6 file right down, super easy to get down on. So sometimes if you are struggling, you can place calcium hydroxide. It can make it a little bit easier because it just kind of, well, softens it. It makes it easier to get down these cases. So keep that in the back of your mind as another little tool in your toolbox. So with the second visit, if they're asymptomatic, I still try to get back down. If I'm short or if I can't find it, I still try. But I don't try too hard. I'm not going to perforate the tooth or destroy it, trying to make it look perfect on the x-ray. It is important to discuss about what's going on, because you need to both tell the patient and the general dentist that, hey, I could not get down here. We talked with the patient, and rather than destroying the tooth, we decided to fill short. They're asymptomatic. We will monitor it, take control of the case at this point, and make sure the dentist knows that it's going to be okay. Remember, you can always do an apico. Surgeries are very predictable. They're a great option here. So if something were to fail, an apico is an option there. All right, what do you do if they're symptomatic? This is where it's going to be a little bit harder, because you've got to figure out what's going on. This is why I like taking the cone beam, because it gives me an idea of where things are. If I'm struggling and I might go down 2 more millimeters, and if I still can't find anything, I may take another cone beam to figure out what's going on. One thing I do like to do with my cone beams is, if I'm trying to find something, make sure you fill up the entire, like if you're trying to find MB2, fill up the entire MB2 space with calcium hydroxide, because that almost acts like contrast. And when you're going through the cone beam, it gives you a much better idea of where you need to look. And this is where measuring makes a big difference. You can actually measure and say, okay, from where the extent of where I am based on the calcium hydroxide to the MB2, I need to go 1 millimeter apically and 1 millimeter distally, whatever it is. It's a really nice way to be able to measure and know exactly where you need to go. C+ files can almost create a canal. This is very useful in straight cases, a little bit more complicated in curvy cases, but you can pre-bend them with curves. So yeah. And then if they're still symptomatic and you don't think it's going to heal, I would talk to them about the apico at that point. So, all right, finally, Pulp Stones. I had to include this image because it's out of it's Journal of Conservative Dentistry. So it's a legit journal. This definitely was drawn with colored pencil. And it's great. I actually love it. Like, if you look at it, it's clearly colored pencil, but they did a really fantastic job of, showing the different types. These are pretty easy. The single pulp stones are easy to pop out. The ones that really start to become difficult are something like this, where it's continuous all the way down to the very bottom. These are a lot harder. So how do we deal with these things for boards? They are also called denticles or endoliths. So just keep that in the back of your mind. They are very similar to dentin histologically, and it's just usually like a mineralized tissue around whatever caused it. It could be blood, dead cells, collagen. But most importantly for us is there are 2 different types. There are attached, where the dentin actually adheres it to a wall. These suck. And there's free, where it's just surrounded by soft tissue. These are super easy. The bleach goes inside there, dissolves the soft tissue, and it pops out right away. These are what you want to have. So with attached, how do we deal with these? The other thing is they can occur near the apex, which really suck. These are very, very difficult to get down to. This is where the C+ files help to kind of pop through at the very bottom. So how often are these occurring? It's actually pretty common. About a third of the population has them in about 10% of their teeth. It is almost always the molars, which makes sense. There's the most space inside there for them. They also take the most force. They're some of the first adult teeth to come into the mouth. So they're some of the first ones to have cavities and fillings. So that totally makes sense. This one, though, there is a very strong correlation with aging. As we age, we see a huge increase in the prevalence of pulp stones. There is a ton of different things that can cause it. And there are also some genetic things that can cause it as well. Anything that kind of messes with either dentin or bone building, or anything with calcium or phosphate can cause issues like that. So how do we take care of these bad boys? Really depends if they're free versus attached. Free are pretty easy. Like I said, they'll usually pop out. But almost always, you're going to have to remove them to gain access to the actual canals. Sometimes you can leave them in the middle. If it's like in the middle of a chamber, sometimes I'll just leave them rather than remove them if they're attached pretty tight. But usually you got to get them out. Ultrasonics are probably the best way, because they just kind of blast them out. It just knocks them loose. Sometimes you'll just kind of touch them and they go flying. So useful way to do it. Burrs can be useful here, depending on, like I said, pick your favorite. Hand instruments, spoons, endo explorers are useful here as well. And then hand files are a nice way to get around them as well. Rotaries, you want to make sure you've done your hand file first before you put the rotary inside there. Okay, finally, the ultrasonics that I use, because everybody likes to know these, they are probably my favorite way to get pulp stones out, just because as soon as you vibrate them, they kind of blast them out. If it is a pulpal one, it works great. Radicular, you're not going to be able to get an ultrasonic down that far. I haven't really found them to be useful. I usually use K files or C files for that. Make sure you have a ton of water in there, because as soon as they get loose, you want to make sure it flushes it out and not down into a canal. I have had that happen. That really sucks when a pulp stone drops down into like a big distal or palatal canal. As far as my favorites, the top one here is what I use almost all the time. It's the Healthy E2D. It has a nice little diamond tip right here. Fantastic little guy. I own more of these than anything else. Back when we only had larger ones available, these Buchanan ones were pretty solid. They're pretty big. That's why I don't tend to use these as much. But the Buck one is very useful to kind of trough. And then these ball or flat-ended ones are useful for attached ones on the pulpal floor as well. EIE makes this nice little workhorse one as well. It's available both with and without diamonds. I tend to like this angle better, but I know a lot of people like this angle here. So I own a ton of ultrasonics. I use this one like 99% of the time, but I own probably 100 because every now and then you need a different angle. Okay, as far as hand files, for getting them out, like I said, it's useful in the canal. One trick you can do is you can actually turn a hand file into an ultrasonic. Once you place the file inside there, I like to use C+ files because they're a little stiffer and they can handle a little bit better. You can actually place it down inside the canal and take your ultrasonic and zap it on the side, and that will activate deep down inside the canal. Now, you have to be very careful with this. You can easily create your own canal, but if you have a pulp stone at the apex that you need to get past, this is a really good way to do it. Once you get past it, up and down, and then use the rotary to pull it up. Head strims are useful for pulling as well. Okay. Conclusions. All right, I made it. Good. Use a ton of different etiologies for calcification. It's useful to know these so you know how to address it. Different things can happen here too. There are a bunch of different ways to address them. I just went through all of them, or all the ones that I like to do. That is not all of them by far. I did use the gentle wave for calcification, just the case I did before here, because I could not get around it. It was super useful for that. But the thing I want to remind all of you is this does get easier. When I was in your chair, I hated doing calcified teeth. When I started working, I hated doing calcified teeth. Now, it's not that big of a deal. They still are scary every now and then, but they become much, much easier the more and more you do them. So get out there and do them. Okay. That was fun. How are we all doing?
How long do your ultrasonics typically last? How many times do you use them?
Depends if I remember to turn down the power or not. So the nice thing about those little Healthy dudes is the end of it's only a diamond in like the maybe third or like 3-4 millimeters. When it pops up, it actually still is useful. You can still use the metal part because it breaks right where the diamond is. So it is important to check and see what the actual, it is important to check and see what the actual power level is supposed to be, because if you go over it, they break pretty quickly. But if you're being kind to them and not doing too much, a while, the shorter the tip is and the fatter it is, the longer they last. I have had the only time I've ever had to replace one of the little posts I use to vibrate, or the things I use to vibrate out posts, is when they get accidentally thrown away. Otherwise, I've had them since residency. They last forever. So
those are stainless steel.
Oh yeah, they're big boys. You've probably seen them before. They're from B&L. It's called the Vibra Post. It's probably 3-4 millimeters thick and long. They're really beefy, but they have a little notch that you can put right on top of the post, and so you can just hold it there and then vibrate the crap out of it, and it really is useful for pop and post out very quickly.
Wow. Good to know. Like
I said, there's a ton of different ultrasonics. So, what other questions do you all have? I know this was a long one.
What's on your Christmas list? What do you want Santa to get you?
Just you, Johnny. All I want for Christmas is you.
Okay.
What about you guys? Anything for Christmas? Wide open, easy canals.
Yeah.
Yeah.
An extra day for break.
I hear that. So cool. Well, I do have good news. I talked to my buddy who's a lawyer. His wife actually is the dentist that I go to for all my airway stuff, and he is totally down to talk to you guys. I need to talk to Craig to figure out when we're going to be meeting next in January. But I think it was Rohan who asked for the contract review. He's totally on board to go over that with everybody. So super excited for that. And then if you have any other things you want me to talk about, let me know. We only have 6 more videos or 6 more meetings until all you second years go off into the big brave world. It's scary.
Oh, God.
I know. I know. Sorry. Didn't mean to bring everybody down right before Christmas, but yeah.
I don't know. 6 months is a long time. We still got a lot of time here.
It's true, but you only have 6 more times with me. That's the difference. Yeah. Are you guys all going to
Yeah.
Yeah. Do you guys go to the IAE?
Oh.
No.
What?
I'm
Yeah.
interested.
You
We
what?
want to go.
You want to
I
go?
want to go.
Okay, let me talk. I know Hatton and I think Roxanne's a member. I'm a member. I think Rhodes has been a couple times. There's a bunch of us who have graduated who are members, so we could like invite all of you individually. But it's in
That's the one for-
Florida.
Yeah.
Um,
Orlando, right?
yeah, it's in Orlando. So the next year it's in I think Manchester. So it's
Damn,
gonna be
missed out.
I need to
Yeah.
go.
Yeah, so
Well, let's go to Orlando.
so you want me to do the one for the UK or you want to do yeah, Orlando? Both.
Both
Yeah.
next year.
It is one of the better ones for sure. So I very much learn lots of things. It's one of my favorite meetings to go to. So I'll be at both of those. So I will at least see you guys in LA. That'll be fun.
Hell yeah.
Get to come to my home state. I don't claim SoCal as anything, but yeah. So cool. All right, guys, we'll go do some root canals. Any other questions? Y'all have my phone number. First years, you could get my phone number from them, and we'll go from there. But have a fantastic Christmas, New Year's, and we will talk to you in 2024. Right?
Sounds good. Bye.
Bye, guys.